السلام عليكم. اليوم بهذا الفيديو راح أكمل لكم الجزء الثاني من موضوع الأورثوغناثيك surgery. In this part I will talk about the mandibular orthognathic surgical procedure. I will talk about the most common surgical procedure and the most important point in each surgical procedure. Mandibular orthognathic surgical procedure can be divided into three sections. The first section, the surgery in the jaw, in which move the jaw in the anteroposterior direction by osteotomy either in the ramus or in the body of the mandible. The second division is the surgery to the dentoalveolar area, such as segmental procedure, to shift the teeth and alveolus but maintaining the integrity of the lower part of the mandible. The third division is the surgery into the chin. Moving the chin, we can move it in any direction, superiorly, inferiorly, anteriorly, and posteriorly, and also on either side. This is sometimes accompanied by reshaping of the chin. This is the three section or three division of the mandibular orthognathic surgical procedure. Each of these procedures we can do it intraorally or extraorally, but we prefer intraorally to avoid scar formation. Before I talk about each surgical procedure, I will talk about the most important protocol in each osteotomy surgical procedure. The most important protocol, the design of the soft tissue incision must maintain adequate blood supply. Also, we must provide the optimum exposure to the site of the osteotomy. Minimum periodontal stripping as possible, and also avoid neurovascular damaging as possible. Mandibular osteotomy, make the osteotomy or any osteotomy any part in either in the maxilla or mandible, cutting on the osteotomy with continuous irrigation with normal saline. And also plan interdental osteotomy cut without damaging the periosteal osseous of the adjacent teeth. Design of the subapical osteotomy must be at least 4 to 5 mm away from the apices of the teeth. Remove all the bony interference. After we segment the osteotomy segment, before approximating the two segments, any bony interference we must remove it. Also, proper approximation of each segment with a stable fixation as possible. Approximation of this segment as possible, class 1 canine occlusion as possible. Class 1, retain the two segments as the class 1 as possible. And finally, adequate coverage of the soft tissue and proper follow-up to the patient. This is the most important protocol in each osteotomy surgical procedure. The first surgical procedure, or the first division, is the ramus procedure. This procedure, the mandibular procedure, either ramus procedure or the procedure in the body of the mandible. Ramus procedure, the most popular one, bilateral sagittal split osteotomy. The main indication of this surgical procedure is to move the mandible in anterior or posterior position for advancement or forward movement or for the backward movement of the mandible. From its name, bilateral sagittal split osteotomy. Its name not meaning always bilateral, but the most commonly bilateral. We can do it unilateral, but the most important point to do is unilateral without doing another procedure. We must do another procedure on the other side. Not doing anything or any other surgical procedure on the other side. Other side must do other surgical procedure if we decide to do it unilaterally. بهاي العملية بالذات unilateral surgical procedure, we must avoid it because we cannot complete the mandibular advancement or backward without any surgical procedure in the other side. So, most commonly, bilateral sagittal split osteotomy, bilaterally, to complete the movement. If we decide unilaterally, we must do another surgical procedure in another side. The most important point in this surgical procedure is to move the third molar because it interferes with surgery in the segmental osteotomy or in the osteotomy side. As seen in this picture, the incision, we have two incisions, vertical incision and horizontal incision. Horizontal incision in the ramus above the linguala. This is the horizontal incision above the linguala, then followed by vertical incision. This vertical incision in the vestibular area, this in the retromolar bud area, and either distal to the first molar or distal to the second molar. The end of the vestibular incision to move the mandible in any direction. The advantage of this surgical procedure, we can advance the mandible or set back the mandible. Also, rigid fixation can be employed. Healing is rapid. Also, it has good stability. But the disadvantage, there is incidence of inferior alveolar nerve damage, but it's rare. Permanent damage, it's rare. Also, the lingual nerve damage, also this is the disadvantage, but it's very rare. The most important point, especially for beginner surgeon, not to more extension. The extension, for example, vertical extension, horizontal extension of the surgical procedure, as seen in this picture. This is the vertical, this is the horizontal incision. This horizontal incision, avoid to extend it more beyond the linguala, as seen in this picture. We prefer to do it here to prevent the damage to neurovascular bundle. But this extension is according to the case, according to the movement, need movement few millimeter, 5 millimeter, 4 millimeter, or more than 5 millimeter. This according to the case. But needs surgical procedure, need experienced surgeon. So we prefer not more extension, especially for the beginner surgeon. And then in the vestibular incision, in the vertical incision, this vestibular incision also we prefer do it distal to the second molar to avoid damage to the neurovascular bundle as possible. After we cut, we have two segments. Proximal segment, as seen in this picture. This is the proximal segment and this is the distal segment. We have two segments, proximal and distal, and then we can move the two segments according to the case, either backward or forward, according to the case. And then stabilize these two segments by surgical wire or by interosseous plate or screw. Also, the most important point in each surgical procedure in the beginning, the infiltration of all soft tissue to control the bleeding during the surgery. We must infiltrate it with vasoconstrictor, with local anesthesia, all the soft tissue to control the bleeding. This is also the most important point in the beginning of the surgery. As seen in this picture, we can also use the drilling and then stabilize the two segments. As seen in this picture. In this slide, I will show you the case that I attended during my rotation in Al-Wasati Hospital in Baghdad. This patient suffering from class 3 malocclusion. We cannot treat this patient by orthodontic alone. We need to treat this patient by combined orthodontic treatment and orthognathic surgical procedure. This severe class 3 skeletal class 3 malocclusion. The surgeon treated this patient by bilateral sagittal split osteotomy. As seen in this picture, after horizontal, first vertical cut, we infiltrate all the soft tissue with vasoconstrictor, and then vertical cutting followed by the horizontal cutting followed by vertical cutting. We have two segments as seen in this picture. This is the two segment, this is the proximal segment, and this is the distal segment. We approximate the two segments by the wire. This is the two segment. We approximate this segment with wire, surgical wire, and then intermaxillary fixation. It's such really very nice case in Al-Wasati Hospital in Baghdad. Then another Raymas procedure, vertical subsigmoid osteotomy. This vertical subsigmoid osteotomy most commonly for setback of the mandible. Setback of the mandible, small setback of the mandible. If there is large setback of the mandible, we need large, for example 10 mm or more. We must use condylectomy with this procedure. We must do it condylectomy or coronectomy for large setback, more than 10 mm, 10 mm and more. This surgical procedure, we can do it intraorally and extraorally, but most commonly extraorally. Intraorally need special equipment. This is the disadvantage, need special equipment. And also, we can do it extraorally. This extraorally, the scar formation. And also, we cannot control the condyle movement. This is the disadvantage of this surgical procedure. The advantage of this surgical procedure is used for mainly for the setback of the mandible, especially small setback. And also the other advantage, this procedure is rapid surgical procedure. And this rapid when we compare it with bilateral sagittal split osteotomy. This most commonly extraorally, because intraorally need special equipment. Extraorally, the incision through mucosa, submucosa, muscle and periosteum. From the subsigmoid notch, as seen in this picture, this incision from subsigmoid notch to the inferior border of the mandible, as seen in this picture. Then, to move the ramus, we have two segments, also two segments as seen in this picture. This is the incision, this is the two segment, this is the proximal segment, this is the proximal segment, and this the distal segment, as seen in this picture. When compare this vertical subsigmoid osteotomy, compare this surgical procedure with bilateral sagittal split osteotomy. The inferior alveolar nerve damage is less than the bilateral sagittal split osteotomy because the inferior alveolar nerve in the proximal segment, not in the distal segment. This inferior alveolar nerve here, not in the distal segment. So, less damage when compare this surgical procedure with bilateral sagittal split osteotomy. The main indication for small setback of the mandible. This is the intraorally, you can do it intraorally. Vertical incision from the ramus to the inferior border of the mandible, to the angle of the mandible, to move the mandible, but not use this very rare intraorally, most commonly extraorally. The other ramus surgical procedure, inverted L osteotomy. This inverted L osteotomy, the same surgical procedure for the vertical subsigmoid osteotomy, the same advantage, disadvantage. The most commonly used surgical procedure for elongation or advancement of the ramus. If there is an asymmetry or hypoplasia, the main indication for elongation, for advancement of the ramus. The cutting most commonly extraorally. This is a cutting horizontal as the L shape, horizontal cut in the ramus above the lingula, then to the inferior border of the mandible. This is the cut as the L shape, and then we can use bone advancement, or you can elongate by bone graft, or can remove the ramus of the mandible, but the most commonly used for elongation. As seen in this picture, also we stabilize the segment by wire, interosseous wire, or by mini plate or screw. Then, other surgical procedure is the body osteotomy. This the first division, ramus osteotomy and body osteotomy, to move the mandible in anterior-posterior direction. The body osteotomy, most commonly when there is edentulous area, because need extraction site to move the body of the mandible, especially in this most indication when there is large body of the mandible with good occlusion. We can divide it into anterior body osteotomy and posterior body osteotomy. Anterior body osteotomy when it's anterior to the mental foramen. Posterior body osteotomy, the surgical procedure posterior to the mental foramen. Anterior body osteotomy, as seen in this picture. Most commonly, when there is large mandible with good occlusion or crossbite in dental nature. We need extraction site either in the first premolar or second premolar. We make two vestibular incision, vertical incision in the extraction site. Care should be taken not to damage the periodontal area to the adjacent extraction site or surgical procedure, and not to damage the mental foramen as possible. After the vertical incision, vestibular incision vertically, we can move with help with the osteotome in the lingual cortex. We can move the body of the mandible according to the case. The posterior body osteotomy, posterior to the mental foramen, also in the extraction site, either in the first molar or in the second molar. We need extraction site, edentulous site, when the patient, for example, class 3, and there is a posterior crossbite dental in nature, or there is a good occlusion but large body of the mandible, and there is posterior extraction site. We can use the surgical procedure, body osteotomy, but not commonly used. Care should be taken in this surgical procedure not to damage the neurovascular bundle. This is the most important point in this surgical procedure, in the anterior body osteotomy or in the posterior body osteotomy. As seen in this picture, vestibular incision, two vestibular incision either side of the extraction area, and then to avoid the damage to the mental nerve, we make the small endo. This small endo to reposition of the inferior alveolar nerve, and then complete the vertical incision below the inferior alveolar nerve until the inferior border of the mandible. This also for repositioning and avoid the damage. Care should be taken not to damage. So to complete the vertical incision below the inferior alveolar nerve, we make this small window, and then we can move the body of the mandible according to the case, as seen in this picture, only to remove it upward to prevent damage to this nerve, and then repositioning after stabilizing the segment by wire or by mini plate or screw. Then the mandibular segmental procedure. This is the second division of the mandibular orthognathic surgical procedure. This to move the alveolus and teeth and maintain the integrity of the mandible. This is not commonly used because most of the treatment can do it with orthodontic treatment. Most of the problem we treat it with orthodontic treatment. So we can be divided this segmental procedure anterior subapical osteotomy or posterior subapical osteotomy. Anterior subapical osteotomy was anterior to the mental foramen, as seen in this picture. The two incision, vestibular incision, vertical incision from the premolar or from canine to canine, most commonly from canine to canine, this anterior to anterior, the mental foramen, from canine to canine, vestibular incision followed by horizontal incision. This horizontal incision 4 to 5 mm below the apices of the teeth. Care should be taken not to damage the mental nerve, not to damage the adjacent periosteum or periodontal structure, and not to damage the apices of the teeth. So 4 to 5 mm below the apices of the teeth. And then with help of the osteotome, extend the surgical procedure. Lingually, with help of the osteotome, fracture this alveolus with the teeth and we can move it according to the case. Most commonly, this anterior subapical osteotomy when there is when we need uprightening the anterior teeth or to leveling of the curve of the spine or to anterior open bite. You can use this surgical procedure, or to move the teeth, to move the anterior segment, for those anterior segment to protrusion or to retrusion. After the movement as seen in this picture, we can stabilize by mini plate, screw or wire. Most commonly mini plate. Then the subapical osteotomy posteriorly. This posterior to the mental foramen. Posterior to the mental foramen, most commonly also for the uprightening the posterior teeth, or for those posterior segment too protruded or too retruded, for correction for the posterior crossbite, most commonly dental in nature. Care should be taken not to damage the neurovascular bundle. This is the most important point in this posterior surgical procedure. 2 vertical incision. We can do it from the first molar to the third molar area, or from the second premolar. We can do 2 vertical incision. The vertical incision followed by horizontal incision. Horizontal incision below the inferior alveolar nerve. This by take a radiograph for the measurement below the inferior alveolar nerve and 4 to 5 mm below the apices of the teeth, and the last vertical incision 4 to 5 mm behind the last tooth, and then extend in the lingual cortex with help of the osteotome to fracture the segment, and then we can move this segment according to the case. The other surgical procedure is total subapical osteotomy. This is very rare use. Totally moving the segment, lower segment, according to the case. If there is large mandible or more protruded or more retruded, for the movement totally. Also, care should be taken not to damage the neurovascular bundle. 2 vertical incision, 4 to 5 mm behind the last tooth from one side to other side, and then with the horizontal incision. This horizontal incision below the inferior border of the mandible as possible. This by radiograph measurement, taking the radiograph and measure the position. And then with help with the osteotome, fracture the lingual cortex. With help with the osteotome, fracture the segment, and we can move this segment according to the case. These surgical procedures very rarely used because most orthodontic treatment can treat the problem. Then the third division is genoplasty. Chin is very important element, as the nose, as the forehead. We can move it in any direction, anteriorly, posteriorly, also superiorly, inferiorly, and either side, if there is any symmetry. Also, you can reshape the chin by the procedure called genoplasty to correct the chin. As seen in this picture, we can move it. We can move the chin anteriorly, posteriorly, superiorly, also on either sides if there is any asymmetry, as seen in this picture. We can divide the chin procedure, genoplasty procedure, into 3 sections. We can divide it as the sliding procedure. Also, we can use autograft from the patient body, bone graft. This autograft means from the patient body, from his bone or her bone. For example, iliac bone. We can use it. Also, we can use stylistic material. So, from patient bone or from stylistic material as seen in this picture, this for advancement, or sliding procedure. This is the 3 surgical procedure in the genoplasty, as seen in this picture. This genoplasty surgical procedure by do vestibular incision. This vestibular incision in the vestibular area, in the symphysis area, separate the digastric muscle from the mandible to prevent the tension as possible. Avoid the tension during the advancement. Also, care should be taken the advancement not to above to 12 mm because the anteroposterior of the chin, dimension of the chin, anteroposterior 8 to 12 mm. So the advancement in this range as possible. The sliding procedure as seen in this picture, sliding procedure by 2 incision, vestibular incision and then horizontal incision below the apices of the teeth, 4 to 5 mm. After these 2 horizontal cutting, we can move the chin in any direction. Also, we can put the bone for bone advancement, bone graft, or also this advancement, stylistic material, plastic material for the advancement of the chin. Also, you can move in either direction if there is any asymmetry. As seen in this picture, this the 2 incision, this the vestibular incision, and this the vertical incision, also the horizontal incision, 4 to 5 mm below the apices of the teeth. And then, according to the case, we can move the chin and then stabilizing the segment by mini plate or screw as possible. هنا كملنا المحاضرة هاي، كملنا الجزء الثاني من محاضرة Orthognathic Surgery. أتمنى استفادتوا من هذه المحاضرة. بهاي المحاضرة شرحت أهم النقاط المهمة من محاضرة Orthognathic Surgery, Mandibular Orthognathic Surgical Procedure. This is the most common surgical procedure. أتمنى استفادتوا من عندها، وإن شاء الله أكمل لكم الجزء الثالث والأخير من هذه المحاضرة. شكرا لحسن استماعكم.